We have known for some time that there are molecular targets that are amenable to therapy. The HER2 oncogene is an example of one that was discovered more than 20 years ago, and the growth factor receptor that is encoded by that oncogene can be targeted with an antibody, with kinase inhibitors, and that has really changed the natural history of the 20% or so of patients that carry that genetic abnormality. However, reproducing that wonderful story has been difficult. It's been hard to identify what the genetic drivers of breast cancer are. We know that cancer is a genetic disease. It's due to abnormalities in the genes. And now that we've developed the ability to sequence the entire genome, we are picking up many more mutations. And so this has really changed the field. And this has all happened in the last 5, 6, or 7 years as we have been able to sequence the tumors of many patients with breast cancer. And what we're finding is that no two tumors are the same. That there are a few mutations that are common, like P53 or PI3 kinase, but after that, the mutations that you pick up are fairly diverse and not that common across all cancers. So this poses a challenge, yet there are many opportunities from the different genetic lesions we find. Some of these genetic lesions are what we call actionable. That means they result in a change in a protein that can be targeted with a drug. And so those are, of course, the ones we're interested in. The other thing that has become apparent over the last couple of years that was presented at the ASCO and San Antonio meetings has been that if we look at the tumors of patients before they get treated with different medical therapies, that we may not pick up some of the mutations that actually make them resistant to that therapy because they are present in very small numbers. However, if we analyze the tumor after treatment, we may pick up some newer mutations. So that was one of the themes that came through in the last couple of meetings. So for example, in patients who are treated with hormonal therapy, we are now seeing that after treatment, some of them have mutations in the estrogen receptor that basically sticks the receptor in the on position. So despite hormonal therapy, the estrogen receptor is still signaling and causing growth of the cell. So now that we've discovered this and have found that there are potentially some ways to turn it off, for example, using high-dose fulvestrant, this now creates a new treatment opportunity. Another mutation that was picked up in patients with triple-negative breast cancers after chemotherapy is a mutation in a gene called JAK2, which initiates cell signaling and cell growth. JAK2 mutations have been known to occur in hematologic neoplasms such as polycythemia vera and myelofibrosis. In fact, JAK2 inhibitor ruxolitinib is approved for myelofibrosis. So now there are clinical trials that are going to be started in patients that have these JAK2 mutations.